Hello everybody. So here are the answers to today's quiz. The first question basically is just showing the clinical picture, which is an 8-year-old male with an erythematous asymptomatic plaque on the cheek since 3 months. Clinically, you may think about granuloma annulare, but yeah, or you may think about sarcoidosis, you may think about lupus vulgaris in an Indian setup. Leishmaniasis again probably isn't differential, so is a foreign body type granuloma. Well, let us see what the histology shows. Histology essentially shows on low power, shows these nice rounded, compactly arranged, coalescing granulomas, which are predominantly composed of these pale epithelioid cells. These are epithelioid histiocytes with a thin rim of these blue cells, which are lymphocytes. So this is what we call naked granulomas, typical of sarcoidosis. You may call them sarcoidal granulomas as well. And this is typical in sarcoidosis, where you see sort of these naked granulomas coalescing with each other in bunches. Um, Now, you may look at this and wonder if these are serpentine granulomas. Yes, I would say these are serpentine granulomas, but not all serpentine granulomas are TB, or sorry, are Hansen's or tuberculoid Hansen's. The reason being, in tuberculoid Hansen's, you don't often see sarcoidal granulomas like this. Though I have seen a couple of cases, and I wouldn't always exclude tuberculoid Hansen's just because the granulomas look a bit sarcoidal. You have to correlate clinically. All right. So essentially, though, just to summarize, these are sarcoidal granulomas on low power, naked granulomas with a thin rim of lymphocytes coalescing together. There are following neurovascular bundles in places. You may even see perineural infiltration in sarcoidosis. That does not necessarily mean it is tuberculoid Hansen's. All right, on higher power, you're seeing sort of a lichenoid infiltrate. The granulomatous infiltrate is destroying the basement layer. You see some subepidermal clefting as well. And yeah, you can make out the thin rim of lymphocytes around these sort of naked granulomas. On higher power, you see this phenomenon in much more close up. You're now beginning to see a few giant cells here. This is one giant cell. This is a giant cell. This is in the small giant cell. What you're also seeing on higher power, you see the giant cells here. You're seeing this incipient epidermal necrosis, very subtle, not epidermal, sorry, the interstitial necrosis, very subtle necrosis developing in the center of a granuloma. Now, this is not diagnostic of anything, to be honest. Any sort of granulomatous response, if the granuloma is big enough, you may find that the cytokines release may cause a bit of tissue necrosis in the center of granuloma. This is described as fibrinoid in sarcoidosis and caseating type in sort of tuberculoid granulomas like in lupus vulgaris, or even tuberculoid Hansen's. You may see that very rarely. But I've mentioned this before. The type of necrosis, whether caseating and fibrinoid, is very subjective, and it does not matter whether you call it caseating or fibrinoid. But if you mention the word caseating, you're usually referring to cutaneous TB. So I suggest you avoid the term unless you know what you're speaking about. So the answer to the questions: this is a sarcoidal granuloma. That is true. Tuberculoid granuloma falls. Pseudoepitheliomatous hyperplasia is absent. That usually is indicator of lupus vulgaris in a granulomatous setup, or cutaneous TB and other forms. Here there is atrophy instead of epitheliomatous hyperplasia. There is no foreign body, which you may want to think of if you're thinking about sarcoidosis. Foreign body granulomas resemble sarcoidal granulomas. Gren zone is absent. Gren zone typically refers to a zone of epidermal sparing. Here, or papillary dermis sparing. Here, there is no sparing of the papillary dermis. The entire dermis is involved. So there is no Gren zone. The final diagnosis, I've purposefully omitted tuberculoid Hansen's here because that would have made the diagnosis even more difficult. Indeterminate Hansen's is easy histologically because and clinically as well, because it presents as a hypopigmented macule rather than a plaque. And histologically, you see very sparse infiltrates, predominantly around the adnexia and nerve bundles, and they're not sarcoidal by any means. So if you look at just the four diagnoses presented here, lupus vulgaris definitely is in the differential clinically. Histologically, there is a lichenoid and granulomatous infiltrate in lupus vulgaris, but it is not sarcoidal. Often you may see caseating necrosis in lupus vulgaris, and there is pseudoepidermolysis hyperplasia, which is absent in this case. So lupus vulgaris is ruled out on that count, but having said that, atypical presentations are common, and sarcoidosis is really a diagnosis of exclusion. So I would certainly in this case do a MAN2 chest x-ray and make sure that the patient does not have any suggestion of cutaneous TB before proceeding to treat the patient as sarcoidosis. Aseptic facial granuloma, which is very common in children, usually presents as a papule or nodule. It is definitely a clinical differential. Histologically, however, the infiltrate is much more polymorphous. It is a granuloma, but you see neutrophils and eosinophils in much larger numbers. But having said that, you don't see a sarcoidal granuloma and idiopathic aseptic facial granuloma, and therefore that is excluded histologically. The final diagnosis here is sarcoidosis. All right, thank you very much.